Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled NP Research Using the Nssrn, and it was presented by David Auerbach and Jeongyoung Park with special guest moderator Peter Buerhaus on January 21st, 2021. My name is David Armstrong, and I'm with the Health Workforce Technical Assistance Center. And today's event is the second webinar in a three-part series on nursing research using the 2018 National Sample Survey of Registered Nurses. And each of these events has been scheduled for under an hour for your convenience. Now, today's session focuses on NP research using the Nssrn. And our final session on February 18th looks at RN research. And for those of you who missed our first event last week on weighting issues associated with the 2018 Nssrn, it is presently available on our website for viewing at healthworkforceta.org. Now, our presenters today are David Auerbach from the Center for Interdisciplinary Health Workforce Studies at Montana State University College of Nursing, and Jeongyoung Park from the George Washington University School of Nursing. And once more, we're joined by our guest moderator, Peter Buerhaus, who is also from the Center for Interdisciplinary Health Workforce Studies at Montana State University College of Nursing. Now, with that said, at this point in time, I'm going to go ahead and turn the event over to our guest moderator, Peter Buerhaus. Peter?
Hey, David, thanks very much. Hello, everyone, and thanks for joining us. I think this is going to be an interesting next 40 minutes or so. I'm broadcasting from Montana, Bozeman, and yes, it is snowing. With that said, I'm just going to briefly introduce our two presenters today. We heard about Dr. David Auerbach last week, so I won't go through everything other than just to indicate that in addition to his work here with our Interdisciplinary Center for Health Workforce Studies, Dave is also the Senior Director for research at the Massachusetts Health Policy Commission. Dave will go first, and then he will be followed by Jeongyoung Park. Dr. Park is an assistant professor at the George Washington University School of Nursing, and she's also a faculty member at the Fitzhugh Mullen Institute for Health Workforce Equity. Jeongyoung is a health services researcher, and she's right at the intersection of nursing, health policy, and health economics. And her research interests include healthcare delivery, payment system changes, and their impacts on the healthcare workforce and patient outcomes. Now, Dr. Park is going to present her study that examined the effects of completing a postgraduate residency program on role perception, practice autonomy, team collaboration, job satisfaction, and intent to leave among primary care nurse practitioners who responded to the 2018 National Sample Survey of Registered Nurses. So a lot of work for her to do this afternoon. All right, with that, I'm going to turn things back over to you, David, and we'll start with Dave Auerbach's presentation.
All right, thanks everyone for joining in. So this week, I'm going to be talking about what you see in the title, are RNs becoming NPs faster? And that's the question that this study is concerned with, but even more so, if so, what does that mean? And I kind of gave away the answer in the title. We find yes. And then what are some of the implications of that? This paper is under review at a journal right now, and hopefully it will be published in not too long. Okay, let's go ahead. Okay, so with a little bit of background, this is from a paper we published in Health Affairs earlier this year, showing, as I think we all know, the number of NPs, that the nurse practitioner workforce has been growing very rapidly. We show here that from 2010 to 2017, supply increased in terms of full-time equivalents from 90,000 to about 190,000. And I just updated that data yesterday with the 2019, and it continued to increase to about 217,000. So very rapid growth. And that growth is really, it's really impressive, especially when you consider how much faster it is than the physician workforce. This was a paper a couple of years ago in the New England Journal, where we kind of compared the growth of physicians and NPs, NPAs, as you can see there. And we found that The NP workforce has been growing about 9% per year towards the right from 2010 to 16, compared to just 1% growth in the physician workforce. Even though the number of NPs is so much smaller, that actually means there are more NPs being added to the workforce each year than physicians. And that is really what's kind of allowing us to keep up with primary care demand and with overall demand for clinicians. Okay, let's go back. And so, given that background, that did lead us to think, how are we doing this? And we suspected that perhaps RNs were becoming NPs more quickly, and a little bit more evidence from that, as you can look at the age distribution of NPs in both 2010 in the yellow and then in 2019 in the gray. You see that the number of especially young NPs really has shot up. And on the left of those bullets in 2010, about 1 in 6 NPs was under 35. And by 2019, it's 1 in 4. That's a big growth. The average age of an NP dropped from 46.3 to 43.7 years. And even though it's true that there's been a surge into the workforce of RNs as well, and they have also gotten a bit younger on average, it's not as much as NPs. Okay, now let's go ahead to, yeah, perfect. So we had this hypothesis that we thought RNs were becoming NPs more quickly. Specifically has the time gap between when you obtain your first RN education and when you become an NP shortened. And another reason we thought this might be true is there's been a growth in the number of educational programs, especially where students maybe with a bachelor's in some other field can go into nursing and fairly quickly progress from directly to an NP in not that many years. And we've also been hearing from a lot of hospitals saying, well, we're really having trouble with our staffing our hospital, where we have a new RN for a while and then right away we lose them to the NP workforce. And that's actually significant, as we explored in that recent paper. So first, we're just going to answer that question of, is this true? And then second, are there workforce implications of that? Specifically, now we have a lot more NPs coming into practice that have spent less time working as an RN before they became an NP. And these are really, these are questions that you can really only answer with the National Sample Survey. Okay, so let's move on. So as for the first question, yes, we do find the time between RN education and NP education dropped. It looks like it's about by 30%. The graph on the left is showing where if you take the National Sample Survey for each survey year, and look at all NPs and just ask, how long was it between your two education programs? In 2000, it was about 13 years between RN and NP. And by 2018 survey, that had dropped to around 10. And then on the right, if you just look at the 2018, the new NSSRN, which has an oversample of NPs, so there's so many of them, you can do this very well. And just ask among those working in 2018, go back to find in the survey when they became an NP, then go back and find when they became an RN and test the difference between the two. You see kind of the same thing, that drop from about 13-year gap to around a 9-year gap. So what we did to then explore this further and find out, are there differences, are there implications for these shorter versus longer time periods? We broke up the sample of new NPs into several groups. We called this first cohort the rapid group. First of all, we took just relatively new NPs from 2020, 2012 and later, and those who had a rapid education progression between RN to NP, that was less than 6 years, that's the rapid group. We compare them to this traditional group who had more than 6 years between the two, and then I'll show as comparison all other NPs who got their NP degree earlier. And just some details of the next tables that I'm going to show. We only included those with the primary care certification to kind of keep it apples to apples. We weighted results by full-time equivalents, and in the significance tests that I'll show, we controlled for age, type of degree, whether it's a master's or a doctorate, region, and years since you've been an NP. And so the results are just the next 3 tables. Will explore demographic differences, educational differences, and practice differences. And just to note, we'd love to know things like quality and outcomes, but we don't have that data available right now. So here's the first result table with just kind of some of the basic demographics of these folks. And I've got the rapid education in the first column. There were 2,097 NPs in that group that we had survey responses from. The traditional group, there were about 5,000 NPs there, and then all other in the third column. So first of all, I bolded some of the key results. This rapid group had an average of 3.8 years between RN and NP. The traditional group, 12 years. So there's a big difference between these two groups. And you can see that the rapid group was younger. The next result I highlighted, which is not surprising, it's kind of falls out of how we've constructed the sample here. And one interesting finding here, no difference in percent female or race or ethnicity, but you can see that these rapid folks are more likely to be in New England and the Pacific regions, which could be related to where some of these rapid programs are in what schools. Then we looked at some characteristics of their educational program and other things like that. And most of these results were not very different, but a couple things I highlighted. The rapid group more likely to have a bachelor's or a master's in a different field before becoming a nurse. And that's, again, not surprising because a lot of these rapid programs have that as a requirement, but it's good to keep in mind. Less likely to have a lot of the content online. And when you ask them in the survey, did your education prepare you to be an independent practitioner? There was really no difference. And that was one of the things we thought might have been different. Maybe they would feel less prepared without having been an RN for a long time, but you don't see that. Okay, and then on to the practice characteristics on the last slide. And a key finding, as you can see, not a lot of bold. Most of these results were, again, not significant. So here we took advantage of the full range of questions in the survey about, are you practicing independently? And we again thought that perhaps with a shorter time period of going from RN to NP, you might have been less comfortable practicing independently. So starting from the top, when you asked what type of care you provide, slightly more likely to be providing ambulatory or primary care for this rapid group, which is important for primary care supply, to think, yes, these programs do seem to be producing primary care providers at a good clip. Salaries were a little bit lower. And then with some of the independence questions, are you satisfied in your position? Not much difference. Does the NP bill with their own NPI? Not much difference. Considered an equal colleague. We found a slight difference on that question. Are you supervised by a physician and have to accept their clinical decisions? Not a lot say yes to that question, but 16% of the rapid group said yes, and 13% of the traditional group said yes. So slightly more tethered to a physician in a way. But can you practice to the full extent of your state scope of practice laws? No difference there. And are you the primary provider for a panel of patients? And pretty much no difference there. Okay. So the conclusion, the average time NPs have spent as an RN before becoming an NP has dropped somewhat from 1996 to 2018. Those NPs with a rapid educational pathway, more likely to be in New England or the Pacific, more likely to have a bachelor's or master's before coming into nursing, more likely to be practicing ambulatory or primary care, but equally likely to say their education prepared them to be an independent provider and equally likely to practice independently on most measures that we could see. And again, as I said in the beginning, we would love to continue to know about, are there differences in the patient's experience of care or in quality or outcomes? And you'd have to have entirely different data to look at that, but of course it's an important question. Okay.
Okay, thank you, David. Jeongyoung?
Thank you so much. And I'm so glad to showcase our study about how the Nssrn data can help us understand the important policy questions, such as whether the completing postgraduate residency training prepare our NP to deliver better care. So the focus of this webinar is using Nssrn data for research. So I'm not going to spend much time in details about this program, but instead I will provide very brief overview of this program and also motivation of this study. So a growing number of NPs are facing increased patient complexity and expectation of productivity as they're working more independently. These challenges are particularly acute for new NPs. So to support for a successful transition to practice, a number of NP residency and fellowship programs have been developed. So the first program in 2007 And currently, a total of 88 programs exist nationwide. So the potential benefit of residency training is widely acknowledged. However, most of the previous studies is based on a single case study or the single programs. So at the national level, no empirical evidence existed. So the content of 2018 Nssrn actually provide both an indicator of who completed a postgraduate residency or fellowship program and the key outcome measures that have been identified as a potential benefit of completing this program from the literature. So the objective of this study were twofold. The first, to quantify the primary care MP that completed a postgraduate training programs. So in this study, we focused on MP who are actively practicing in primary care. So in doing so, instead of using the field of their MP educations, we used their clinical specialty area in which they were spending most of their patient care time. So by using these definitions, we identified about 76,000 PCMP nationwide, and about 10% of PCMP completed the residency training. So, and then second objective of our study is to compare two groups, PCMP with and without residency training in terms of their demographic and practice characteristics and patient panel characteristics, and most importantly, the 5 domains of benefit of completing these programs, including the role perception as an independent provider, and practice autonomy, and team collaboration, job satisfaction, and intent to live. Again, these are built up from the evidence from the literature. So this table is the result roadmap under each category. So details about each measurement and analytic approach will be available in the soon to be published paper at the Journal of American Association of National Practitioners. So I will just highlight the key findings in the next few slides. So first, we compare several personal and practice characteristics listed in this table and found statistically significant differences on their age, sex, race, ethnicity, and total earnings. So PCMP with residency training, they tend to have minority background than those without. So they were more likely, slightly more likely to be male and non-white and Hispanic. Next, please. And we also analyzed the patient panel characteristics using a subsample of MP who reported having their own patient panel. So PCMP with residency training reported more patients in their own panel, and they also tend to see more underserved population with minority background and with limited English proficiency than those without. So this figure shows the odds ratio and 95% confidence interval from the logistic regression on each of 10 outcome measures under 5 domains we identified. So none of the 2 role perception measures are statistically significant, but PCMP with residency training were significantly more likely to report greater practice autonomy and improved team collaboration and increased job satisfaction and decreased intent to leave than those without. So in summary, this is the first study to compare outcomes between MP with without residency training using a nationally representative sample of MPs. So this study suggests that completing residency training was associated with important health equity factors, including increased diversity in MP workforce itself and also service to minority and underserved population. And findings also reinforce the prior research on the benefit of completing this program. So in conclusion, these studies support the further expansion of such programs, which could have positive effect for MP workforce, but ultimately for patient and healthcare organizations. So, and several limitations also need to be recognized. First, this study was cross-sectional, so making causal linkage impossible. And second, we are unable to control for the program characteristics. And third, we rely on self-reported outcome in the NSSRN, which always subject to potential recall or reporting bias. And lastly, the outcome we used in this study are unlikely to reflect the full spectrum of the program outcomes. So as Dave mentioned, as we begin to think about the longer term policies, we really need to consider how these programs impact the access, cost, or quality of patient outcome. So this should be explored in the future research. So this is the end of my presentation, and I look forward to any comments or questions. Thank you.
Okay, thank you very much. And just a reminder to those of you in our audience, you may ask questions of our presenters using the Q&A panel on your screen. Now, with that said, Peter, do you have any questions, comments you'd like to ask to kick off this session?
Yes, thanks, David. And thank you both, Dave and Jeongyoung, for your presentations, and you're right on time and really interesting bits of information on the growing NP workforce. I have a question quickly for Jeongyoung. I didn't see it in your study, and you may not know this information, but do you have any sense of the cost of residency programs in general? Are these expensive programs? Is there a lot of variation in the costs, or is that something you just haven't looked at?
You mean in the cost in terms of the residency training or
Yes.
the program itself? I don't have a clear number at top of my mind, but on my slide, I listed references, which is a recent publication by the Keystone and her colleagues, I think at Journal of American Association of Nurse Practitioner. She conducted a really comprehensive national environmental scan about the program characteristics. So it has a lot of information about, the cost, tuitions, or what content of the curriculum they cover, etc.
Okay. Great.
So
Thank you.
I'm sorry I cannot answer the
fine.
exact, but if you or other audience are interested in the program characteristics, then please, check that papers.
Okay, fine. And Dave Auerbach, I noticed that you showed the beginning slide where you had data through 2017, and you reported that with new data out to 2019, it grew out to about 217,000 NPs. Do you recall if you looked at the earnings of NPs going out into 2019? It looked like they were starting to slow down in the figure, and I just don't know if you did that or not.
Yeah, I have the data, but I didn't look at earnings in 2019. But right, and I think you noticed on the graph that I showed there, earnings did steadily increase while supply was increasing, which right, one might worry, is there are there so many NPs coming onto the market that some of them might be, are wages being bid down? Is there oversupply? Are they having trouble finding jobs? Yeah. So it's important to keep tracking that, and I'll let you know what I see in the 2019. I think in the 18 data, the earnings didn't drop, but I do think that the growth might be slowing a bit.
Okay.
Yeah, good question.
Great. Thank you both. David, I'll turn it back to you for other questions that people may be wanting to ask.
Yes, we actually have a couple questions that have came in. Jeongyoung, this is for you. Well, for the second presentation, have you considered controlling the year of graduation from NP programs, which is available in the Nssrn? It might be related to age, but year of graduation seems a better control for the analysis.
This actually, as the the question actually has answer as well. So we check the age and the year of graduation from MP program. It's really highly correlated, but we actually chose age instead of the year of graduation because there are some kind of missing variable in the year of graduation part. So we used age as a proxy for their tenure in the MP kind of practice, etc.
Okay, thank you.
Mhm.
Okay, we have another question. There are several nurse retention programs for new nurses subscribed to by many hospitals. These seem to have been successful in retention of recent nurse graduates. Are the NP residency programs anything like them and having similar success?
I think the ultimate purpose is same. However, the residency program is really prepare them to stay in their primary care jobs. So as I said, there are no national level evidence. However, we saw a lot of like anecdotal kind of case study that the successful residency training or a successful like onboard kind of program is really associated with the decreased kind of intent to kind of leave or a greater retention. So that's, I think, show the same kind of success outcome, however, a different kind of approach, but have the same kind of purpose or goals.
Okay, thank you. Okay, here's another question. Hello, thank you for these presentations. I wondered if you considered looking at acute care residency and fellowship programs.
So as I said, there's a limitation. Unfortunately, there are no information about the program characteristics. So we assume most of our primary care nurse practitioner actually went through the primary care focused kind of residency program, but we are not 100% sure that they were actually went to the primary care focused residency program. So that's a big limitation, but I think kind of collecting this kind of information or data is really beneficial for further research. But I know that that requires kind of a big commitment from the funders or the stakeholders. But however, that's a really necessary and important part for the data collection for further research.
Okay, thank you. And David, this one's for you. Is there a difference in scope of practice for practicing in inpatient settings versus outpatient settings? Seems like inpatient practitioners might be more likely to be specialists in NP programs.
That's a good question. And no, I didn't look at that, but it would be very easy to do in the data. I'm just going back to that results slide where, yeah, about 16% of these primary care certified NPs were in inpatient settings. And it would be interesting to see if they note a difference on the scope of practice questions. I mean, my general sense is that scope of practice restrictions don't tend to matter as much in inpatient settings where you're usually working on, in broad teams with physicians around, and the supervision just isn't as much of a barrier. But I would certainly like to just go and check that and get back to you if you have your contact info. That's a great question.
Okay, thank you, David. And this next question is, I'm not sure we can really answer it, but I'm going to ask it because there's some people in the audience that might be able to answer it. And that is there a plan to change the data collection for the next Nssrn to collect more specific information about NP postgraduate training programs and retention and characteristics of the programs themselves? I don't have any information on that. I can't really say anything myself. And I'm Peter, David, does anyone have anything on that? Well, anyway, that's a question from the audience. And so perhaps if we find out that answer, we can get back to you on it.
David, I do believe that the folks at HRSA are expecting to conduct another national sample survey in the next few years. And, in the past, they've always been receptive to comments and questions. And this one would seem to be an easy add to the survey, but I don't want to speak for them, but I would just say, suggest that on up to HRSA, and I bet you people would be receptive.
Yes, and I'll definitely pass that on, just to let you know. And HRSA, they are planning to conduct this survey again in 2022. That's the present plans. And they presently are reaching out to different researchers, you know, asking for feedback on the last NSRN to help improve it. So we will definitely pass this one up. Okay, and that's all the Q&As we have from the audience at this point in time. With that said, to each of our panelists today, David, I guess we'll start with you. Do you have any final thoughts regarding your research that you would like to share with our audience?
On this topic specifically, I think we covered it pretty well. But you know, one thought is just that there's so much that can be explored in this national sample survey. You know, last week I talked about some issues with, you know, with race and ethnicity, and you know, I certainly have that in mind as I did this work, and it's important to make sure you're, you know, seeing if there are correlations there. But really, the survey is just so rich that there are, you know, an infinite number of studies you could do and questions you could ask. So I just really encourage people to, you know, go through the questionnaire, go through the code book. It's very easy to get the data, and you know, I'm available for questions too if there are any.
Okay, thank you. And you know, we have had a couple more questions come in while you're talking for you. So maybe before we move on to Jeongyoung for her final thoughts, we can go ahead and squeeze these in, okay?
Yeah, go
ahead. David, how are you differentiating, you know, PCNPs from other NPs in the Nssrn for your inclusion criteria? Is there a specific item related to this, or are you creating this by employment setting?
Right. And that's a good question. And it's interesting that, you know, it's relevant that Jeongyoung used more. There are different ways to think about this. You can look at what people were certified in their educational program versus what they are actually practicing as. And she used more of a practice-based definition, whereas I used one that was more education-based. And that's really because of the question I was asking in my work, was kind of going back to the original NP education and starting from there, and then asking, one of my outcomes in a sense was, now, you know, in what capacity are you practicing? But so it could really be done either way. And I used the questions on what is your certification specialty. But again, there's questions where you can then go in to see, to get a sense of, are you acting as a primary care provider, which is different. A lot of NPs train as a primary care provider, but then go on and practice in more specialized ways. Okay, go ahead. And the second question, I can just say, yeah.
Well, do rapid versus traditional NPs seek different settings of care, i.e. different models of care, for example?
Yeah, that's a good question too. And I have looked at some of there's quite a few excellent questions in the survey about team-based care that I think Jeongyoung used a little bit of. And I didn't explore those in this study, but I have in other ones. And that is possible. That is possible. And that's a good question to follow up on, which I haven't done yet.
Okay, thank you. And now, you know, kind of back to my previous line of question, Jeongyoung, do you have any final thoughts you'd like to share with our audience regarding your research?
Sure, yeah. It's actually related to my topic, and also in general. Like, I know the survey was originally designed for estimating the nursing workforce characteristics or evaluating trend or some projecting the future workforce, but very limited information really available for us to understand how best to prepare our nurses for kind of a changing delivery system or payment system, or some kind of expectations from the patient or public. So for example, many hospital or healthcare organizations are operating under ACO model, but we have no idea whether nurses understand the economics of this ACO model and how to manage this goal. So the kind of data collection like this area is really necessary.
Okay, and another question from our audience. Did you look at how many are educationally prepared to remain employed as RNs because of salary? or job opportunities?
There's again, no, but a answer. There's a lot of questions in the survey about, because a nice thing about the Nssrn compared to like a census-based survey is it includes both RNs who are practicing as an RN, but also those who might have left nursing and are doing something else. And there's a very long list of questions that asks why exactly. Is it because of, of earnings? Is it because of burnout? Is it because of opportunities? So it's quite detailed and rich on that question.
Oh, yes. Actually, we found that about 18% of licensed NP are not employed as an NP. So they can be like either they are not working, but also some part of them are actually working as an RN, even though they have NP licenses. So we don't know why, but yeah, it's really an area we need to further explorations.
Okay, thank you. And with that said, well, Peter, do you have any final comments on our event today?
No, other than just to say, the data is publicly available from the National Sample Survey. It's is easy as a couple of clicks away, and there you are. And as Dave was saying, there's just so many questions and different things that can be addressed. But Jeongyoung also said there are other things that aren't being addressed, and maybe in the future, the National Sample Survey could kind of consult with you, Jeongyoung, to talk about some of those other questions. It would be great to add in more, but then, at what point the
happy to
can you
do
it?
yes.
Yeah. But
Yeah.
anyways, but thanks very much, David, and thank you, Dave, and thank you, Jeongyoung.
Thank you so much.
Yes, thank you, both of our panelists. I thought they were fabulous presentations, and thank you in the audience for attending our event. Hey, we hope to see you again next month. That said, have a good afternoon.
Thank you.
Goodbye.
Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.